Hello, everyone. I want to thank the organizers for inviting me to speak to you today. I will talk to you about prevalence of vaccine hesitancy in the United States and pathways we can combat this not only US problem, but a global problem. Here are my disclosures. The objective of my presentation today is for you to know the causes of vaccine hesitancy and the prevalence in the US, to learn of strategies to counter false messaging, and to know ways to strengthen the relationship between your role and community needs, and also to understand the importance of addressing cultural concerns and leveraging local leaders. So what is vaccine hesitancy? Back in 2012, WHO's SAGE work group has met to define vaccine hesitancy. And their definition is still valid. It is defined as delay or refusal of some or all vaccines. As shown on this slide, vaccine hesitancy is a spectrum where people may simply refuse single or all vaccines or just delay because they are not certain that the vaccine is either beneficial, they need to do some additional research or need additional information to boost their confidence in accepting vaccine. Vaccine hesitancy is context specific. It is a complex issue. It's influenced by several factors: complacency, convenience, and confidence. I will start by briefly reviewing prevalence of vaccine hesitancy in the US, but I will start by highlighting that vaccination is the norm in the United States. Here you're looking at a linear graph that summarizes vaccination coverage for children ages 24 months of age between 2011 and 2019. And as you can see, I know we don't have a pointer, but so you can see at the top of that graph, most of the children in the US are fully vaccinated against the common vaccine preventable diseases, polio, MMR, and hepatitis B, and the vaccination coverage is high at over 90%. There are two vaccines where childhood vaccination is low, specifically Hep A and influenza vaccine. Similarly, for kindergarteners in US, vaccination coverage is good, with over 94% of children, kindergarteners, being fully vaccinated with those two doses of MMR, DTaP, and varicella vaccines. In the United States, all children need to be properly vaccinated to enter school. Each state has an immunization law that clearly defines what vaccines are required and what exemptions are permitted for children whose parents don't want to vaccinate. So for example, in New York State, vaccination laws allows only for medical exemption. We are one of the few states that has removed non-medical exemptions to combat the rise of vaccine hesitancy. Currently, all states in the United States offer medical exemptions. So children who cannot be safely vaccinated, they can get a medical exemption. 6 other states only allow medical exemptions. For other states, non-medical exemptions are allowed, with parents who claim philosophical, religious, and personal belief objections to vaccinations. Those children can be exempted as well. So I'd like to highlight here that you can see the percent of exemption is listed at 2.2%, which appears to be a rather low number, but it's important to know this is country level data, and even when you look at the state level data, they appear pretty small, but those numbers can obscure the level of hesitancy and under-vaccination in certain communities and schools, and I'll tell you a little bit more about that and why this can be a problem. So the school immunization laws are incredibly important because they boost coverage, they provide equity, and as you can see in this slide where you're looking at percent of children vaccinated, and those are US adolescents, the vaccination coverage for Tdap and meningococcal vaccines shown here in the red and deep blue color at the top of the graph is pretty good, but the vaccination coverage for HPV vaccine in green and MenB vaccine is very low, and those are vaccines that are typically not required for school entry. So you can appreciate the immunization gap that's been created by vaccines not being required for school entry. Similarly, for adults, here you're looking at flu vaccination in green. 50% of adults have been vaccinated against flu in 2021. Not shown here, COVID-19 vaccine, for example, 15% of adults have received updated COVID-19 booster as of May of 2024. So again, low coverage, high hesitancy. So I mentioned the notion of exemptions and why parents would choose not to vaccinate children. Back in 2006, Omer and then Salmon have coined the term of exemptors and geographical clustering. It's important that we recognize that people who do not, parents especially, who do not vaccinate, they are geographically clustered. We have looked at school exemptions in New York State, looking at private schools specifically, and measured the exemption rates at those schools, and the data is summarized here for you. And as you can appreciate, looking at different private schools by different religion, the rate of exemption differed significantly, with Mennonite and Amish students had very high rates of exemption, 60%, and I can tell you in some of those schools, 100%, all children were unvaccinated. And you can imagine what that does to school and how can that easily breed an outbreak of measles or pertussis, and it only takes one case. Compared to public schools where the rates of exemptions were very low in New York State. Second to the highest, secular private schools. Those are your Waldorf schools, were second with the highest exemptions and parents refusing vaccines. It's important to remember that none of the major religions objects to vaccination. So we raised the concern that parents actually who claimed the religious exemptions back in New York State were actually claiming those exemptions in lieu of their personal beliefs or philosophical objections to vaccination. Since then, New York State has removed non-biblical exemptions to combat hesitancy and improve vaccination coverage. Similarly, so outside religion as being one of the reasons why people do not vaccinate, wealth and affluence was a strong predictor for vaccine hesitancy and refusal. We have looked at California private schools back in 2014-15 and stratified our analysis by tuition. We used tuition as a surrogate for parental income, and found that students attending schools where the tuition was greater than $10,000 per year had 2 times the odds of not being vaccinated compared to children who attended less expensive schools. So of course this sort of raises a concern that the burden of vaccination is being shouldered by those less fortunate and less privileged in our societies. And again, highlighting that geographical clustering alone is a significant problem, and exemptors have been linked to outbreaks of measles and pertussis in the United States. So what are the common causes of vaccine hesitancy? Misinformation, and Dr. Stewart has already touched upon, as misinformation and disinformation travels quickly through social media and social platforms. I have practiced and continue to practice in a community in upstate New York where a 17-year-old girl died following a 3rd Gardasil dose. Gardasil is an HPV vaccine. This was back in 2007. Gardasil was rolled out in 2006. And this story hit media, and essentially this was a girl who was by her teachers described as this all-American teenager, blonde, blue-eyed girl who loved softball and hit the slopes, snowboarding. And one day she was found on the bathroom floor. And it was a day after her 3rd Gardasil dose. The autopsy didn't reveal cause of death. And her mother has become a strong anti-vaccine and anti-Gardasil advocate. She went on media, was on TV, has gained a lot of attention and traction. urging parents to research this vaccine before they vaccinate their own children. The story has affected the community very heavily, and even now, 17 years later, we still struggle to get children fully vaccinated with HPV, and the vaccine remains highly controversial. Distrust in institutions is really important factor that undermines vaccines acceptance. As you all know, during the COVID-19 pandemic, by then, before that, most Americans really didn't know what it takes to get a vaccine license in the United States, but with the COVID pandemic and FDA and ACIP sort of publicly sharing information, all Americans have become suddenly experts in vaccines, and people got a glimpse into what it takes to get vaccines accepted, but licensed. But at the same time, the process has showed its possible vulnerability because there was the perception among Americans that the vaccine licensure and approval is susceptible to political pressure. During the COVID-19 licensure process, many Americans thought that the vaccines were rushed to the market without properly tested for safety and having the vaccine's efficacy properly evaluated. So unfortunately, the distrust and the perception that it's politics that drives public health and not public health driving politics has lasting impact on vaccine hesitancy. Dr. Stewart already touched upon this cause, cultural, religious beliefs. It's really important that when we approach communities or individuals, we are mindful and sensitive to the pre-existing attitudes and beliefs people have, so we don't alienate them and communicate in a manner that allows them to relate to us, so we can boost their confidence in vaccination. Fear of side effects is the single most important factor that leads to vaccine refusal, and risk perception is another important factor. Because vaccines work so well and the immunization coverage, especially for childhood vaccines, is very good in the US, we don't see a lot of vaccine preventable diseases. Parents no longer see what polio does. They don't see they don't see measles. As such, they no longer fear them. And the perception of the benefit of vaccination is shifted, and fear of side effects arises, and as such, that balance is disturbed, and many people will choose not to vaccinate. So given that the vaccine hesitancy is context-specific and it's a complex issue, what kind of strategies can we develop to address this problem? It will require a comprehensive approach. Education and awareness of public and individuals is key to help people understand the benefits and safety of vaccination, help them understand the severity of disease that vaccines prevent. Fact-checking. Dr. Stewart has already talked about it. Fact-checking is really important as mis and disinformation travels quickly through social media and is shared and is more likely to be shared than accurate information. Engaging platforms that can mark false and false information or misinformation is really important to alert people early on before misinformation becomes viral. So some of the strategies that have been successful in increasing trust in healthcare systems include transparency. Transparency is a path to building trust. FDA and ACIP, they do provide public viewing of their sessions and of their meetings, but we also, as institutions, organizations, and individuals, need to be able to acknowledge what we know, what we don't know, and what else needs to be done, rather than just broadly make statements and make ourselves vulnerable to providing incorrect information or maybe false reassurance. Cultural competence needs to be taught. I know it's one of the areas that's being taught in medical schools early on. Really important that providers are sensitive and understand that their patients may have different cultural and religious beliefs and attitudes, and addressing those people in a manner that will enhance the relationship and build trust is critical. Community engagement, that has emerged during COVID-19 pandemics because we recognize that having a vaccine doesn't mean people will take them. We have worked closely with Black and African American communities trying to deliver COVID-19 vaccines, and worked with religious leaders and community leaders to help us communicate with their members, because there was so much distrust between institutions and their communities. So community engagement is key. Provider training, here the training refers to communication strategies, and I know Dr. Stewart has already addressed some of those. I'd like to talk to you about 5-step approach and how can one utilize motivational interviews to boost communication with hesitant parent. Before I talk about that, Dr. Stewart and myself, we have been successful in receiving funding to work with communities up in upstate New York, where the HPV vaccination coverage is really low. And we will employ community-based participatory research where we will collaborate with the community leaders, religious leaders and parents and students, to engage them and have them lead identification of barriers with the ultimate goal of designing intervention to turn the tide on the low HPV vaccination in that community. So we're very excited about this opportunity. So what can providers do to enhance their communication strategy with hesitant parents? There are two tools that I'd like to share with you. Using a presumptive approach when you encounter a parent who's bringing a child, or adult actually, who comes for a visit. Essentially, presumptive approach is effective in boosting acceptance rather than using a participatory approach in your communication style. Presumptive approach is more likely to get your patient vaccinated. For parents or patients who still are hesitant after you employing the presumptive approach, 5-step approach is a useful tool. For providers, it allows customization of the communication strategies that resonate with the cultural values and individuals' values. The 5-step approach includes these 5 steps. You establish empathy and credibility. Then you briefly address the specific concerns. It's really important that we don't just blankly assume that parents are concerned about safety, or parents are concerned about vaccines causing maybe an infection. Just it's really important that we identify what the problem is so we don't actually trigger hesitancy. And then you quickly pivot to disease risk, you convey the vaccine effectiveness, and then you end and close the conversation with a strong and personalized recommendation. During the COVID pandemic, I have collaborated with the Institute of Vaccine Safety of the Johns Hopkins Bloomberg School of Public Health, and we have developed Let's Talk Shots, a website. It's a free award-winning site for providers and patients. It individually tailors vaccine information. It's available on smartphones and tablets and computers, and it uses short animations and videos that are tailored to the user's specific vaccine attitudes and beliefs. And it's built on evidence, and it uses the power of the story. We cover all vaccines, all ages, and the website is provided here on this slide for your convenience. I encourage you to check it out. Here are some screenshots from the website. At the core of the website is tailoring to individuals' needs, attitudes, beliefs, concerns. And it uses a very simple language to communicate science. So the viewers can actually absorb the information, find it relatable, and seamlessly learn about different aspects of the vaccines, whether they are concerned about vaccines ingredients, whether they question whether they need to be vaccinated, and so on and so forth. So in fast-paced, I have reviewed with you prevalence of vaccine hesitancy in the United States, and we've gone through some of the strategies that have been shown to be effective in boosting vaccine confidence. So what can we all do to help combating vaccine hesitancy? So if you are a researcher, maybe the action number 8 would be for you. If you are in public health domain, public health official, raising awareness and sharing accurate information about vaccines, and under number 1 would be for you. And if you are a provider, learning how to counter misinformation and how to properly communicate with your patient is really important to boost confidence, vaccine confidence. I'd like to acknowledge my colleagues at Johns Hopkins, Dan Salmon, Matt Dudley, Peter Orton, and Neil Halsey, Walt Orenstein and Emory University, and Talisa Stewart here at Upstate. And I thank you for your attention.